So the first question really addresses the issue of how stroke patient care has been improved or is advancing internationally, and we'll have comments from our panelists. And for the first one, we'll start with Dr. Bunney, just giving some insights from her perspective in the U.S.
Yeah, so when just thinking about answering some of the ways in which we're looking at stroke care, I think that in the context of a lot of the other emergency medicine issues that we're having, one of which is ED boarding, where our patients are staying in the emergency department longer, our hospitals are incredibly full, and so it's been difficult to move patients out. And as we have patients who are coming in who may be a bit on the undifferentiated side still, as we're trying to continue them on their stroke care workup, we're desperately looking for ways in which we can manage these patients effectively and be able to use our space effectively as well. And there's been a few areas that have been exciting for how we've been able to more efficiently and effectively work with our stroke patients. So at a couple of shops that I've been at, we've had ED run observation units, so being able to put some of our lower risk stroke patients into our ED observation units for being able to do 24-hour stays, to be able to have them get their MRIs, their TEEs, as well as any physical therapy they may need. We've also recently implemented in the last 6 months new MRI scanning, particularly the NeuroMix MRIs, which allow us to get these scans done within a matter of minutes, and have been shown to have very good rates at being diagnostic for ischemic strokes. And then another really interesting approach that has been taken is actually for those patients who are concerned with having TIA, we're actually starting to discharge those patients. And we're not discharging them to the ether, but in working with our neurology colleagues, who are able to get an MRI within 72 hours of discharge. And so being able to have this coordinated care pathway for our patients as an outpatient to get them the care that they need without keeping them in the emergency department or keeping them in the hospital long term.
Thank you very much. Dr. Fenyves?
Here. So I collected these few points as you can see on the slide. So one of the things that was initiated in Hungary, I think like six years ago, was this AI-supported imaging tool by Agrait, the e-stroke suite, which was distributed amongst stroke centers across the country. Obviously at some ways university as well, which is now proven has proven to fasten diagnostics and give us better door-to-needle times as well. And another new thing that has been established is this criterion to transport LVU suspect patients directly to thrombectomy centers. Unfortunately, our department is not the thrombectomy center; it's a lysis center, but we have the ARC, but we don't have thrombectomies yet. It's just another part of the city. And those patients who the EMS finds to have a race of 5 or more, then they would directly be transported to that center. And I actually would be curious about if you use any of these or what's your experience with it, because there's a wide range of data saying like how sensitive or how well predictive this scoring is. But anyways, one other thing that we initiated, which is quite unique. So normally we use the Canadian triage system, modified Canadian triage scaling, so 1 to 5, and normally a stroke patient will be a candidate for a triage level 2, which does not provide immediate physician care, but only nursing, and like the physician and the provider is like 15 minutes. But we arbitrarily said that okay, these stroke suspect patients should be triaged once, so that they get a more immediate care and they can get to imaging and to lysis faster. And the fourth point is that what we discussed, or what I talked about in the last previous session, is about what to do with the patients, whether we should focus on guided therapy or not. So these are the currently going and interesting things.
Excellent, thank you. Dr. Agrait?
So the coming from Puerto Rico, we're way behind a lot of the U.S. on stroke care, and there's a lot of reasons for that are way too complicated to get deep into. But basically, the things that are improving is we are now teaching EMS on LVO recognition. We have essentially accelerated pathways for endovascular care, similar to a hub and spoke model. It's not exactly that, but There's really only one EBT certified center on the island, so if you happen to have a stroke in the southwest corner of the island, you're at least 3 hours away from that center. So how do we transport that person to a facility that has a CT scanner, that has a radiologist that can read it, that has TPA or TNKs available, that can then ship out to the stroke center? So all of that is kind of being built up over the last year and a half or so. Functionally, we're very much rural medicine, even though technically we're not rural. The health system works in that way, and it's similar to rural healthcare in the US. And therefore, it's very fragmented, and a lot of the EMS companies don't communicate with each other, don't communicate to the hospital before they get there, which obviously is not the optimal for stroke care. So again, it's about kind of establishing how these things go and improving even the very basics of recognition, transfer to the appropriate facility, and going from there to the endovascular center.
Thank you. Very good. Dr. Lewandowski.
So for me, I just listed one thing, and this comes from the perspective of taking call for stroke for many years. So I was part of the stroke team, and one of the nicest things that's happened to us is getting the CT perfusion scans, which initially when we got CT perfusions were incredibly labor intensive and difficult to do, and you had to be physically present to pick out your areas of interest and all this other stuff. Now that there are AI models for streamlining all this, there are two companies, Rapid and Viz, and we happen to use the Rapid one. It was a decision made by an administrator because it was less expensive, but still I can have it on my cell phone, and I can actually see the patient's medical record now on my cell phone, and I can literally see their imaging coming off the CT scanner. And so these are the slides I showed earlier, and so I can see this as it's available through Rapid AI right onto my cell phone during a patient evaluation when they present to the emergency department. So this was life-changing for us.
So you can distinguish infarct from ischemia or ischemic penumbra.
Or yes, and actually what we can actually see with Viz AI is the plain CT. We can get the aspect score, and we can see which areas are hypodense. We can see all of the CT angiogram cuts, so you can actually score through it. And really, the AI does not help you much in terms of actually finding the LVO. But what it does is that it processes the CT perfusion scan very quickly, so you can see that scan as it comes off the scanner itself.
Excellent, very good. Our next topic is international management of patients who sustain traumatic brain injury, knowing that expats around the world are frequently involved in motor vehicle incidents as pedestrians and as drivers. Our first commenter will be Dr. Agrait. Thank you.
So I think, again, this is coming from somewhere that's a little bit behind the rest of the U.S., but recognition of TBI, everything from mild TBI or concussion to TBI with bleeding, and then therefore preventing the secondary harm is the most important advancement we've had in Puerto Rico. We now have, again, kind of expedited care for these patients, for some of these patients anyway, and we can, in conjunction with neurosurgery, discuss what we're doing in terms of cerebral pressure monitoring and avoiding hypoxia and hyperosmolar agents if necessary, and then shipping them out as soon as possible to an appropriate center.
Do you have neurosurgery coverage at more than one or two major centers?
Sort of. We have plenty of neurosurgeons, but the vast majority of them do not do either endovascular care or TBI care or bleeding that is not subdural in a little lady. So it's a problem because our hospital, for example, has neurosurgery coverage, but not for this. So for TBI, we have to ship them out to the only trauma center on the island, which is, as usual, too many patients, too many TBI patients, too few physicians, too few nurses. So it's a real issue about how long do you keep that patient, you stabilize, and do you keep them maybe an extra 10, 12 hours because the receiving facility just can't take care of them at the moment.
Okay, thank you. Dr. Bunney.
So with regards to TBI, thinking specifically about mild TBI, I know at our shop, we see a lot of people who have either falls or minor MVCs, and more often than not, they've always said that they've hit their head. And so what we know though about minor traumatic brain injury though is that upwards of nearly 50% of people do not necessarily return to their neurologic baseline, and less than 10% of those patients get follow-up. And so while there's not a lot of interventions we necessarily do in the emergency department, being able to identify these patients to be able to get them to the next stages of care is really important. And so what we've started to see come out of the woodwork is actually new devices that are being used for EEG and portable EEG in the emergency department to allow us to start to diagnose the early stages of mild traumatic brain injury. Some of these devices are even going so far as to trying to detect blood in the brain so that it can help with decision making for CT scans, though they're not quite there yet. They're really allowing us to prognosticate and diagnose our patients so that we're able to get them the neurological care that they need. And it's proving to be a useful tool given the large number of patients that we're seeing with this.
Thank you. Dr. Lewandowski.
So for me, we've done a number of trials with severe traumatic brain injury, including looking at progesterone and other things for that, and albumin and other stuff. But really, the study that's ongoing right now is looking at the partial pressure of oxygen in brain tissue. So these are people that have severe brain injuries. They have an ICP monitor through a bolt. And right now, we're evaluating the use and utility of also monitoring brain tissue oxygen levels. And so this trial is underway. It's recruiting very well, and it's moving along. But this was like another eye-opening experience for me, because when we were managing patients with ICP plus the brain tissue oxygen levels, I had two patients, and one in particular on the next slide, that was a young man who was 18 years old, was hit by a bus, had a severe brain injury, and he was randomized into both the PBTO2 arm with the ICP monitoring. And this is an open study with blinded adjudicators at the end. However, this was now the second patient that I had seen in just a handful of patients, where every measurable parameter, blood test, urine test, and whatever you could figure out to monitor was normal, except for one thing, and that was the brain tissue oxygen level. And once again, I learned that you never know till you know. And with this fellow, we corrected it as soon as we found it, and he actually turned around quite quickly. And in following this patient, he had about 2 or 3 months of a personality disorder after the severe injury, but then came back to himself after that. And it was just an amazing case that demonstrated to me that we just need more information on these patients. And even though you think that you have them well tuned up and you monitor them and every parameter is normal, we really may not understand exactly what's happening in the brain. And this is now another level of actually getting to be able to monitor people and adjust their ventilatory parameters to deliver oxygen to where it really needs to be.
That partially answers my question. How do you treat deficient brain tissue oxygenation?
So there's a number of things that you can do, but mostly head of bed elevation, ensuring perfusion, and then what we do is you can actually increase the oxygen level on the ventilator itself to bring it up. And when we do these monitors, we do a daily test. So we actually bump up the FiO2 to 100% and make sure the monitors actually show that bump and are working properly, and then bring it down to.
Thank you. Dr. Fenyves, any thoughts about hair and Hungary?
Yeah, so the reason I didn't bring a slide is because Hungary is very unique in a way that the trauma care and non-traumatic emergency care is only separated. So in Hungary, we as emergency physicians, we only care patients up to only do patient care around non-traumatic patients, and ortho trauma is a specialty that does everything that's trauma related. So honestly, I myself don't really see TBIs because they just don't much appear at the EDs. They sometimes do, obviously, but then we just transfer them to neurology department or neurosurgery department if they do so much.
Thank you. So, Dr. Fenyves, you can begin just speaking a little bit about research systems and what progress you're seeing and developments from your perspective.
So we found that we've been putting a lot of energy into bonding more and more with the neurology departments, so with the neurologists, obviously in terms of data collection and data sharing. And we've been trying to put ourselves on the clinical trial map of not even Hungary but in Europe, because not many EDs are considered as clinical sites. That's what we see, and many of the sponsors, most of the sponsors don't even know that you should look for an ED if you are looking for patients who are in the acute phase of a surgery illness. So we found it is not true only for neuro studies, but for all the other studies that we've been able to engage in the last few years, that by building a study team of coordinators, nurses, and training sub-investigators, and like branding ourselves as well, that we are able to do that. So we actually managed to get a few trials to run at our ED, obviously with the collaboration with the other departments for follow-up. But in some cases, we found that our study team is actually that well organized, so we are able to follow up patients. Our team is able not to follow up patients at other departments who don't have the human resources or the staffing to do that. And the other thing that we've been working a lot with is working together with IT to improve our EMR system and our data collection system to be able to run studies and do prospective studies by not putting extra burden on the physicians and the providers, and not having the need to have coordinators or other assistants to do patient data collection. Just by improving our regular clinical forms should let us do analysis a few years later on those high quality data collections. And we are in the middle of this, so we don't have anything that's been published by this work, but this will take time, and I think it will pay itself in a few years.
Thank you, that's very good. Dr. Agrait?
So the ability to use things, simple things, like using your phone and video conferencing with a neurosurgeon or a stroke neurologist has been in use for many years, but has come into much broader acceptance over the last year or so in Puerto Rico, and we now have a way of communicating with the stroke service on any suspected LVO, and we can even discuss it directly with the neurosurgeon who's going to be taking care of them. There's the caveat that the endovascular neurosurgeon was a groomsman at my wedding, so it's a little bit of a bias myth, but it's allowed us some direct contact with the service that's going to be taking care of this patient, and that's in the process of being formalized kind of throughout the island, and hopefully will be over the next year or so. That's going to be something that we have ready to go for any suspected LVO case out in the field, not just in the emergency department.
Thank you, very good. Dr. Lewandowski?
So I think that collaborative research networks are huge, and we learned this with the NINDS TPA stroke study in terms of collaborating sites, and it was actually 30 hospitals, most of which were community hospitals in that trial, and then the leaders of that study were able to start to create a hub and spoke model and convince NINDS to actually fund one of the first such collaborative efforts called the NET Treatment Trials Network, Neuro Emergencies Treatment Trial Network. And the design was that you have a clinical coordinating center that then works with various hospitals, and each hospital is a hub that then works with a number of spokes so that you magnify the number of sites that are actually doing the research. And so with 10 hubs, and if each one has 5 spokes, you can get 50 hospitals working together on a single trial. The network is a little bit more complex than that previous schematic, but really it has at the core of it funding from the National Institute of Health. It has a coordinating center, it has a data management center, and it offers opportunities for individual investigators to actually propose trials or to collect pilot data, then propose trials, and then the coordinating center and the steering committee will refine those ideas, and then if they actually, and help get those grants funded, and then once funded, they have a big network to shoot them out through. So to me, the important thing is that you can get involved in these things because it offers tremendous faculty development opportunity, that it allows you to develop international and national connections throughout, and these programs actually answer questions much more quickly than you could at any single center site. So over the years, it's evolved from NET to Siren and StrokeNet, and so those are, to me, really incredibly wonderful programs that really are advancing care, and often, through the emergency medicine's perspective, because, the NET really was the biggest amount of money that the NIH ever invested in emergency medicine. And I'm proud that the emergency medicine community stepped up and was incredibly productive.
Thank you. Dr. Bunney.
So what I've been really interested and excited about in terms of research moving forward has really been our ability to leverage data to, in particular, look at improving stroke outcomes. And so really opportunities for now making these multimodal data sets where we're combining original structured data with new language data as well as then imaging data, and being able to use this all together to be able to formulate our models with regards to patient selection and predicting outcomes and complications. Importantly, also as considering the model building and things that are being developed in terms of techniques for mathematical optimization is the fact that a lot of these models, when they're being built in healthcare, are being built on many, many variables. And they're looking to predict something in 6, 12, 24, a week, 30 days. And we're looking at the next 5 minutes. And that data that they love to use is not available. Those predictors or those variables are not available. And so how can we build this for emergency medicine at the time that it is actually needed with the variables that we have with the patient in front of us? And so being able to optimize that to make it work for emergency medicine has also been really exciting.
Great thought, thank you. So we will have some final thoughts from our 4 panelists. We'll start with Dr. Agrait.
All right, so I think Puerto Rico has a unique opportunity to kind of be at the forefront of building a stroke care network. In how you do that in a resource-limited environment with a very broken health system, and it can be an example of how to do this in the U.S. and rural healthcare systems, and even around the world. So we should use the fact that we're kind of behind the times as an opportunity to create a way of doing this in the future across the U.S. and across the world.
Thank you. Dr. Bunney.
So I think in terms of moving neurological care in the future is looking at innovation through both devices and software, and the integration of the two. We're seeing new things being implemented in our emergency departments, but I think it's not only important to be moving these innovations forward, but actually taking a moment to do so safely and effectively. And so these areas, I think that can be addressed with these can be through, validation tools as well as validation methods. So going back to our basic research methodologies, looking at Agrait, the integration process, and so what does it look like to initially do technical implementation, silent pilots, prior to actually having it affect patient care. Looking at the sustainability, so is it something that is actually, one, answering a reasonable question that needs to be addressed, and something that we have infrastructure around for data monitoring in the long run that an institution would be able to support, and so not something that's just put into care and left to itself. And then finally, really the ability to capture the value. And so looking at how we can actually be treating our patients and looking at the outcomes that we're delivering, as well as then improving the way in which we're able to care for our patients, whether or not there's financial or other methods that allow us to actually improve care.
Thank you. Dr. Lewandowski.
So,
There we go.
So I think that emergency medicine is a great specialty. It's fairly young in its development. It's very dynamic, and it's really wonderful to see, you know, this many young faces coming to carry on the next generation of work. And I think that this specialty is continuing to develop in so many unanticipated ways that it's really fabulous. And I'm very grateful for meetings like this that bring so many people together to actually exchange ideas and carry our specialty forward. So in the big picture of things, I think this is a very encouraging and uplifting meeting, and thank you all for attending.
Then our host, Dr. Fenyves.
Thank you. So I think I didn't prepare slides for this now, but I have one final thought which I've been thinking about recently, that our local protocol has changed a lot since in the last 10 years, let's say. And I think one of the most important things that we found is that you have to put a lot of emphasis on the training and on the feedbacking and recirculating the quality control, and to assess and aware that what you plan to do is like, does it make sense, or is it working or not? And we had a time when we have a poster about this. So at Semmelweis there was a time when Agrait first was the approach primarily for CT, for stroke management, and you just really have to be very cautious about, you introduce a new method, a new protocol, a new way of patient flow, and then you have to keep track, is it working or not? And I think that's especially with stroke management, where everything is happening very rapidly, and you see all these papers coming out, every month basically, like, should you thrombolize somebody in the 24th hour or not? So you really need to be very on the spot, on the top of this.
Thank you. So, in summary, this has been a great panel. Thank you to our panelists. I want to really say thank you. You prepared slides ahead of time, and that allowed us to get through a lot of concepts in a very short period of time. But we addressed 2 neurological emergencies. We talked about the way in which research is being done effectively internationally. It's good to hear about increased collaboration and the important role that emergency physicians play as the initial person who evaluates these patients. In determining better patient outcomes. I'm personally curious to see how AI will help us to make decisions real time as data comes out, because currently you wait for guidelines and then you wait 7 years later for those guidelines to be implemented. So we'll be curious to see how perhaps AI can help to speed up the process of educating all of us who are practicing in improving patient outcomes. Are there any questions from the group? Otherwise, we're pretty much on time, but we can take a couple of questions if anybody has a question. Yes, sir.
I've just got a question of curiosity regarding the brain tissue oxygenation. How do you guys quantify that and measure that? Is it invasive methods or non-invasive methods?
It's invasive. It's a probe into a non-injured part of the brain.
Okay. How do you know when that probe is in the part of the brain that you need it to be in?
We get a follow-up CT after placing all the probes.
So it's more like IR kind of placement. Okay. Thank you.
Thank you. Oh, one last question. Go ahead. Please.
I'm very curious about AI technology with Ottawa rules, Ottawa echo rules. There are so many rules here, but in your rules, Ottawa stroke rule, I think, is there any study or idea about new implementation or new or policy approach to change the rules? Because every rules from experiences or statistics of result of the like a treatment. I think AI technology can implement a new rules and a holistic approach, or easier rule, maybe the new criteria, like yeah. I think I already obsessed with AI technology, plus new implementation of the rules or other things. And the other question is about, Professor, this is the things the tissue, partial tissue brain oxygenation. How about thinking about hyperbaric therapy or electron transmission? I mean the cyclic AMP pathway or other things.
So I think part your first part was on implementation science, and there is a lot of work done, and that's kind of a new science that's coming out. How do you actually translate things that you've done and developed into actual action? So implementation science, I think, is making advances on actually getting rules out there. I know that in our shop we're using our electronic medical record to use the various rules so that you can link to them directly from the patient chart based on what you've charted what the chief complaint is to the appropriate rules, and then you can pull in right into your medical record so that you can actually do those. I think the other part of your question, with TBI about looking at hyperbaric medicine, there actually is a trial ongoing now called HOVIT, H-O-V-I-T, that is enrolling patients with severe TBI into hyperbaric chamber care. The thing is, it's hyperbarics with traumatic patients. If they have multi-system problems, can be difficult. But there are centers that have large hyperbaric oxygen programs that actually can do this fairly well.
Thank you again to our panelists.